Good morning, everybody. First of all, I would like to thank PCSI for inviting me to share some of my experience about the ductal stenting, especially in complex ductal anatomy. PDA stenting is a high-risk procedure because the patient is a very small baby, so we just use very limited size of introducer sheath, maximum 4 or 5 range. The PDA is easy to be spasm when we cross the guidewires, the catheter, or the stent putting inside. The morphology of PDA is sometimes very difficult with the long and tortuous PDA, and most patients are severe patients with a high hemodynamic compromise, cyanotic, and acidosis. And what is the challenging cases for PDA stenting? The challenging in the morphology of the PDA for stenting. The challenging is technical issue for stenting and the challenging situation for everybody. Let me start with the challenging morphologies for PDA stenting. The simple morphology for PDA stenting is the PDA arising from the descending aorta, very straight and easy for crossing the guide wire, advance the sheath, advance the guiding catheter, and stenting. The complicated morphology of PDA for stenting is the vertical PDA and very tortuous PDA. One kind of the challenging PDA for stenting is the branch pulmonary artery stenosis. Manzani from Malaysia, he say if any branch pulmonary artery stenosis is a absolutely contraindication for PDA stenting. You can see many cases for the PDA stenting with a bifurcation or trifurcation stenosis. You can see the stenosis may be at the ostium of the LBA or RBA, or sometimes stenosis is the long segment, or sometimes it's due to the angulation between the LBA, RBA, and the PDA. It can create the stenosis of the branch. But some more severe cases, you can see the LBA or RBA sometimes very small and the hypoplasia due to the very severe stenosis and long segment. Some cases you cannot see clearly the LBA there, and these are very difficult cases. And when we put the stent inside the PDA, sometimes the stent slips far and it can create the LBA or RBA stenosis due to the stent. Sometimes the PDA is too small, too short, and when we put the stent not short enough, and so the stent gel one of the LBA or RBA or confluence. And so how to deal with the trifurcation or bifurcation stenosis? In my practice, I prefer to do the first stent from the PDA crossing the stenosis to the LBA or RBA, any branch of the pulmonary artery. And second stent or third stent, I put to cover total length of the PDA. And of course, the remaining branch of the pulmonary artery become smaller or more stenosis. And what should we do for the remaining stenosis of the other branch of the pulmonary artery? For discrete stenosis of ostium or RBI and LBI, we cross the further second guide wire and use the balloon. Of course, we start with a small balloon and further dilatation with a bigger balloon. And for the opening the throat, and you can see we can get a good result with the balloon dilatation. When we open the throat of the stent, the question is how big is enough for increase the pulmonary circulation and not for gelling the stent. We cannot put a very big balloon and also not too small balloon. The answer is the balloon should not to be over the stent. It means it's not bigger than the stent. If you use a 4 mm stent, we cannot use more than 4 mm balloon for dilatation of the throat of the stent. For this field stenosis of LBA and RBA, I mean the long segment stenosis of LBA and RBA, and sometimes we need not only the ballooning but also stenting the BA branch. You can see this patient with the PDA stenosis and also the LBA and RBA stenosis with the long segment. First, I put the stent from the PDA to the LBA, and I crossing with the second guide wire to the RBA, and I use a balloon dilatation the throat of the first stent to open the ostium of the RBA. But due to the long segment, and I should put the second stent from the first stent to the RBA, and you can see we can get a good result. And here is I want to share to you the very difficult case, the very severe stenosis at the trifurcation from the PDA and LBA and RBA. It's very difficult for crossing the guide wire. But when I put the stent from the PDA to the RBA, you can see the LBA almost disappear, and it's very difficult for crossing the guide wire through the stent to the LBA for using the balloon for dilatation or using the stent. And after try to cross the guide wire through the first stent to the LBA, I use very small balloon to the dilatation. And you can see after increase the size of the balloon, the LBA still stenosis at ostium. And so I should put the second stent from the first stent to the LBA. And you can see we can get a good result. And how to prevent further stenosis of LBA or RBA due to the first stent. You can see in this case very severe stenosis of LBA and RBA. And if I put any stent from the PDA to RBA or LBA, I will make the other become more stenosis or even though totally occlusion. And what should I do? I prefer to put the guide wire to LBA or RBA first. In this case, I put to RBA and use a balloon to dilate the hole or the ostium of the RBA first. And I put the stent from the PDA to the LBA. And with the RBA open before, and I'm very easy to cross the guide wire again and use the stent or balloon to dilate the RBA. And you can see we can get a good result. And the second kind of challenging PDA morphology for stenting I want to share to you is the tortuous PDA. According Mansani from Malaysia, he say if the very tortuous cause or one or more constriction is a very difficult technical issue for the stenting. Maybe it's not safe. The question is the tortuous PDA can be stenting or not. According to the Mansani, the PDA with the two or more curves is so-called the tortuous PDA. And of course, the tortuous PDA is very difficult in technical issues. And of course, the length of the PDA and the length of the stent should be considered. In my practice, I can do PDA stenting for all kinds of tortuous PDA, but I prefer to use 2 or 3 short stents better than one long stent. I don't think the one long stent can cover totally of the length of the PDA because very tortuous length. And the first stent I prefer to put in the pulmonary end. And you can see the second stent, I can select the length of the stent for cover, the remain, and also how long for the overlaps. And you can see it's very easy for the second stent after putting the first stent. And one kind of the challenging case for PDA stenting is a bilateral. You can see the each of the branch of the pulmonary artery supplied by each of the PDA. And the problem is the size of the stent for each pulmonary artery. If we cannot use very large or we cannot use very small stents. And of course, we put 2 stents for 2 PDA and for LBA and RBA. But the question is the size of the stent. In my experience, the size not too big. Maximum size of the stent is 3.5 for each pulmonary artery. The second thing I want to share to all of you is the challenging techniques for PDA stenting. Most of PDA stenting patient is very small baby, and so the very important thing is how to fix the guide wire as far as possible, making the guide wire strong enough for supporting the stent advancing. I use a twisting technique for anchoring the guide wire as more distal as possible. You can see when the tip of the guide wire goes very far, I twist the guide wire and make the floppy part of the guide wire fixed together, and now we can push the guide wire as more as possible. And maybe the micro catheter can help for twisting the guide wire and make sure that the guide wire will not be broken due to the twisting. An interesting technique for advance the second stent inside the first stent. I prefer to use the technique so-called the inflate and deflate the balloon for advancing the guiding catheter crossing the first stent. You can see I inflate the balloon, and when I deflate the balloon, I advance the sheath, and the sheath cover the balloon and go inside the first stent. Even though when the first stent and the vessel with the angulation very sharp, and but with technique, you can see the guiding catheter can go inside the first stent very easily. And from that, the second stent can advance through the first stent should be very smoothly, even though any angulation between the first stent and the vessel. The one difficult thing in technical issue is the size of the stent, especially in the patient with the large ampulla but very small the PDA opening axis in the pulmonary artery. If we put the small stent or enough stent, you can see some space between the stent and ampulla is a high risk for thrombosis over there. And what should I do? I prefer to use the two stents. The first stent, I put the small stent in the pulmonary end, and the remain I can put the bigger stent for the ampulla. And you can see the bigger stent in the ampulla, bigger ampulla and small stent in the pulmonary artery. And so I can prevent the thrombosis, and I also can keep the blood flow to pulmonary artery is enough. And the last one I want to share to you is some challenging scenario in PDA stenting. The first challenging scenarios I would like to share to you is the PDA stenting with the PDA sputum. It's very often when we cross a guide wire or catheter, or sometimes we put a balloon or a stent. And you know it's a very difficult situation if PDA sputum during procedure. The patient will become very severe condition and also very severe hemodynamic compromise. And the problem is when we stop the PGE1 for tortuous PDA. If we stop very early, we have problem with the PDA sputum. If we stop a little bit later, the PDA may be still big, and it's also the difficult thing for the PDA stenting. In the situation of the PDA sputum, which one should we do? I mean the balloon for dilatation PDA or street direct stenting, or can we use the PGA1 again to open the PDA? It's very difficult for answer. One more challenging scenario in the PDA stenting is the PDA rejection. You can see the PDA can be dissected by the guide wire and catheter, or even though the microcatheter. In this case, the PDA is not too small, but I could not cross by guide wire. I use microcatheter, and you can see the PDA sputum and almost totally occlusion. I try to cross again, but later you can see the PDA dissection and totally occlusion. The patient become very severe condition. And how to deal with the dissection PDA during the PDA stenting? Of course, we cannot cross easily the dissect PDA. And can we use the PG1 to open the PDA again? Of course, cannot, because the patient condition become worsening very soon. And this case we can try to do, but almost a case, very severe case. The next challenging scenario is stent micronization. to the pulmonary artery or aorta. You can see the stent is easy to slip to the aneurysm, I mean the post-stenotic aneurysm of the LPA or RPA. And what should we do? You can see the embolized stent can cover the ostium of the other branch of the pulmonary artery and create a new onset stenosis. And I try to put the second stent for cover totally the length of the PDA and use the balloon for opening the stenosis branch of the pulmonary artery. Broken wire is the big problem for PDA stenting, especially when we try to cross the guide wire through the throat of the stent for opening the throat. And you can see the guide wire can be pain and cut very easily due to the stent. And you can see this case, I crossed the guide wire through the throat and the guide wire is broken. I tried to push a second guide wire with the purpose to remove the first guide wire by the catheter and snare, and the second guide wire also be broken, and the third guide wire also be broken. And totally 3 broken wires inside the LPA. But luckily, I can use the snare to remove totally of the guide wire outside the body. But the stent will be pain and will be gelled very easily due to the snare, catheter, and the guide wire. And pay attention on the stent after remove the guide wire. But surgical remove also very difficult for surgical approach because the guide wire go very distal inside the pulmonary artery. And how to avoid the broken wire. I prefer to use a microcatheter to cross to the tip of the guide wire. And when the totally of the guide wire inside the microcatheter, I can remove the guide wire without any broken. And for my conclusion, PDA stenting is still a difficult procedure. All cases are challenging cases because most of patients are very severe patients and very small babies. But it's a very interesting procedure. The result is acceptable for waiting the surgical repair later. And thank you very much for listening.